To ASA Live. My name is Cindy Morris. I'm the Vice President of Development and Community Engagement here at ASA. We are really excited for today's program. We are going to be talking to our friends at Compassion and Choices as we really kind of dive into an understanding of the differences in end-of-life palliative care, hospice, and kind of what your options are and your choices are in all of this. Joining me today is our friend Kim Callinan, who has been the Executive Director over at Compassion and Choices now and a wonderful partner of ASA's. And with us, in addition to that, is one of their board members, Dr. Chandana Banerjee is with us, and she is the Assistant Clinical Professor and Director of Graduate Medical Education at the City of Hope Cancer Center. Thank you both for joining us today as we talk about everything. Let's start off with introducing yourselves. Kim, can you maybe explain what Compassion and Choices is, how you got involved in this work as you are really working to address the inequities in end-of-life care?
Sure. So thank you so much, Cindy, for having us on your show again today. It's always one of the highlights of my week whenever I get a chance to be with my friends at ASA. But I have Compassion and Choices is the oldest, largest, most vibrant national organization that's committed to improving care and expanding options at the end of life. And we work across the full breadth of options, everything from advancing hospice care, palliative care, advanced care planning, also to expanding the options that are available to people around medical aid and dying. And in terms of the work around inequities, one of our focuses as an organization has been around expanding access to end-of-life options by advancing medical aid and dying, which is the option that somebody can have if they are terminally ill with a prognosis of 6 months or less to live, that allows them to be able to take a prescription medication to end their suffering if it becomes too great. And that's one of the things we're known for and what we tend to get the most attention around. But the reality is that that's only one small aspect of our mission. And our mission is really much broader. And about 5 years ago, we brought together different leadership councils. We had a council of leaders from the African-American community and from the Latino community. And we were doing work around advanced care planning. And we were also trying to advance medical aid and dying. And I kind of looked up one day and I said, I'm trying to understand, why is our organization and the movement so white? And, we do have some leaders, some really, great leaders, but why are there not more? Why is this not an issue that resonates, that you care about? And what I heard back was, people, of course, everybody's going to die. We all do care about the mission. But right now, if the organization's primary focus is on expanding access to end-of-life care, while that's something we all support, we're trying to get access to the basic care that's out there. And for you to diversify the movement, you're going to need to diversify your programming and make sure that you're programming that addresses the full breadth of end-of-life issues. And that's really kind of was an eye-opening moment for me, where it made me realize that we needed to think about our work and our mission in a different way.
Yeah, it's very interesting as we're gearing up next week for our Generations Forum on promoting health equity. This is a piece of that story. And I think that's one of the reasons why we're excited to be having this conversation right now, because we are looking at health equity far more holistically as an organization. And I know that end-of-life care is a piece of that story. And so we're hoping everybody can join us next week as we talk about that. But Dr. Banerjee, why don't you kick us off here? Can you introduce yourself, share how you got involved in this work and why this matters to you?
Thank you for having me, and thank you to ASA for really addressing this important topic. For me specifically, I went into medicine after my father's unexpected death, and really the suffering that I saw around his death. And, as I went through medical school, I always knew I was going to work with underserved populations. And typically in residency, when every physician trains, you see a lot of disease management, you see a lot of ensuring that patients are being treated for and getting all the absolute latest technologies and medications for curative aspects of their disease. What I didn't see much was really care that is surrounding end of life and serious illness, which really was why I entered hospice and palliative medicine, to address that aspect of it. Because like Kimberly said, we're all going to die. And when it comes to serious and complex illness, dying is also medicine. There's an art to it. There's an art to making sure that we still care for the patient appropriately towards their last stages in life, which is so amiss in medicine, and now is being looked at more by medical schools and by programs everywhere that are training physicians, as something that is important for any physician's training or any clinician's training. As a matter of fact, you can't not discuss end of life and what it takes to treat patients at the end of life. If you're truly in medicine, it has to be addressed.
Right, they're so intricately related. In Kim's description, she talked about hospice and palliative care. Can you perhaps explain the difference between those and when a patient might receive each one?
So these are two disciplines in medicine and in our social medical context that actually have very similar goals. They both look at offering relief from pain and symptoms that are a result of serious illness, right? They both, as disciplines, address the emotional, social, and spiritual needs of patients and their families, bringing together a multidisciplinary team of chaplains, social workers, nurses, physicians, right, volunteers. The major difference is that with palliative care, it is care for people at any stage of their illness. A patient does not have to be terminal in their disease. They do not need to be selecting not having a curative treatment. So for example, when you look at hospice, patients that sign on to hospice, which is really a continuation of palliative care, they usually in the last 6 months of their life, or they've chosen to forego their curative treatments. That's what makes them eligible for hospice. With palliative care, you can actually get palliative care right from the beginning to the very end of your disease. You can actually, with certain diseases, be cured, and palliative care will guide you through that process. The goals for palliative care are basically patients get support in their symptom management, the families get support as they're going through the disease and the journey with the medical providers. With hospice, the goal becomes more of getting the care, but focusing more on quality of life at the end of life, right? You're not looking for curative treatment there. You're looking more to enhance your quality of life as you are in that terminal state. And many patients choose palliative and they continue with palliative. And many of these patients, when they reach the terminal aspects of their disease, then transition onto hospice, which really provides that ultimate quality of life and comfort for them and their families.
So palliative care is kind of what will lead you into hospice, if I'm hearing you correctly.
If the disease becomes terminal. So with palliative care, you could subscribe to palliative care and then continue with palliative care, which will give you this multidisciplinary team and will give you everything you need for symptom management and disease burden symptom management. But then you could actually be cured from your disease, at which point palliative care would stop. If you don't get cured, then you progress and you go on to that terminal phase of your disease, in which case palliative care will continue. And then you subscribe to hospice, which is really an enhanced version of palliative care.
So tell us a little bit about your experience as a provider. Why do you think that these inequities are are existing at this point in advanced care planning and in hospice, in palliative care. Where do you think that's stemming from?
So I think really that's a very important question. And I think right now, more so, if you look at everything in the political and social context as to what's happening in the country, you can see that healthcare disparities and inequities really get their roots from systemic and structural issues. Palliative and hospice care traditionally follow similar trends that other healthcare issues do. Um, you can see that there's access issues, there's cost issues, there's cultural issues, there's social economic issues. And all these, if you look at the populations that are underserved and not getting the appropriate care that they should be getting, you'll see that there's a systemic and structural map to this. Homelessness, Native Americans, so many people that come here as immigrants just don't have that access that many of us do. The simple fact that people don't have enough access to appropriate insurance to even get the basic needs that they need to have, makes it a deeper dive into what kind of access will they get when it comes to end of life if they're not getting their basic accesses, right?
Which I assume connects also to the trust issue, right? Because if I don't have access to healthcare or equal access to healthcare, then I'm probably not forming a trusting relationship with a provider who I know. And so what is the relationship of trust in this?
So we know as clinicians, it's very apparent, and as patients, it's very apparent that trust and communication are two critical aspects of any medical care that goes the right way. Right? You usually have a breakdown in medical care when either trust or communication is not transparent or present. I think one of the issues that you find is that when you have a lack of trust and when communication is not transparent, between patients and the providers, you find the patients not making informed choices towards the end of life, right? When you don't make informed choices, inevitably you're going to subscribe to treatments and invasive treatments when they are not needed. When that happens, families and patients see the suffering that they go through, and the most important thing is that when they are suffering and when the families see their patients suffer, that's when they start thinking, why is it that this was not made clear to me, right? Why is it that my provider has not discussed this with me? Why don't I have the same options that other patients have? And it all comes down to the communication at that point. So trust and communication, I think, go hand in hand when it comes to patient-provider relationships, especially at the end of life, because we know that in general, underserved populations, because historically have been left out of receiving the adequate treatment, they need to have that trust with physicians in order to be able to make the appropriate choices. And when that communication is not present, trust is not going to be present.
Right. If I haven't received adequate treatment because of lack of access, this is another piece of treatment. Am I receiving adequate treatment? Again, and I'm hearing that. Kim, can you talk about the idea of non-beneficial treatment and what that means? Why getting treatment would be bad?
Sure. But actually, before we go to there, can I just go back to something that Dr. Banerjee said that I think might be of interest to your readers? So she gave the kind of clinician's perspective around what she sees in the population. But one of the things that Compassion and Choices did was we did a whole literature review around what are the what causes inequities in end-of-life care and what does the clinical research show. And we produced a report that you can find on our website that details the findings. But we looked at Black, Hispanic, Latinx, Asian American, Native Hawaiian, and Pacific Islanders, the indigenous populations, and LGBTQ. And in total, we looked at like the last 4 or 5 years. What is the research that's out there showing around advanced care planning, hospice care, palliative care, pain management, and non-beneficial treatment. And what we found was exactly what she articulated, which is that across all of the historically underserved populations, they're less likely to have access to palliative care, to end-of-life care planning, to hospice care, and they're more likely to receive aggressive end-of-life care or non-beneficial treatments. And so I thought that broader context might be helpful. In terms of non-beneficial treatments, and this is one of the hardest things for people to understand, because you go through your whole life, and especially if you're from a community that doesn't get good access to care, you're fighting for the best care possible. And so the assumption is medical care is all good. But the reality is our medical system is designed in order to focus on saving life at all costs. And that's the sort of paramount focus of most doctors. But the reality is there comes a point in every person's terminal disease where, or not every person, but many times in a person's disease, there becomes a point where treatment has now become futile. And in fact, some treatments can result in a lot of pain and suffering and actually make the end of life worse. And I guess the way that most people might sort of connect to this is around some cancer treatments when you're in the clinical or the experimental phase, and they can result in a person really having debilitating symptoms. And the reality is they're not extending life, but they are actually causing more suffering. And in some instances, it actually reduces the length of time. But the challenge is that it's not always clear to the patient, are you in that moment or not? And the patient, of course, wants to live, like the alternative doesn't look very good. But those trade-offs aren't necessarily shared with patients. And, Dr. Banerjee alluded to this in the beginning of it. It's after the scenario that people look back and realize what's happened to them or what's happened to their loved one. But at that point, it's too late. So part of what palliative care does and why palliative care is so important is it's working alongside of curative treatment. And it's helping, it's like, I always think of the palliative care doctors as the patient's coach or the patient's advocate. And they're helping to translate clinical medicine in comparing and compassionate ways to that patient to say to them, yes, these treatments are available to you, but let's be sure you understand what those treatments may mean and what they won't mean. And so things that are really difficult, like this, no matter what we do, we don't have a cure for your disease. Like, this isn't about curing your disease. Now tell me, what do you want the end of your life to be like? Like, do you want the end of your life? Is there a special moment you're waiting for? Do you have someone's wedding you want to go to? Or is living so important that giving up the potential of being cognizant and aware for those memories is worth it to you, that you want us to try that aggressive treatment? So palliative care doctors come in before the person has gotten to that point, and they're their coach. And so it's the opportunity before you're talking about death, before they're terminally ill, to start to build a trusting relationship with a doctor, where that doctor is focusing on, how do you feel? The whole purpose. Instead of simply focusing on, oh, your disease is X, here's the treatment for that disease. And that's where, to me, the power in palliative care is, and the opportunity between the connection of palliative care and hospice care really is.
Right, right. And so I can almost see why underserved populations might get more invasive treatments, because they may not have had access to that first moment of coaching that was needed at that palliative care with a palliative care specialist. I'm jumping to that conclusion. Am I crazy? Is this what I'm hearing?
That is absolutely part of the reason that those communities are more likely to get invasive treatments. There are others, though, also. Some of it's cultural. If you're the person who's been fighting for care your whole life, that idea of giving up may be difficult giving up, which is, of course, we don't view as giving up because we're all going to die, but that is in our culture, that is sometimes how it's viewed. So that's another reason. I would say physicians' discomfort with being honest is another reason. It's really hard. And I'm not a physician. Dr. Banerjee can speak to how hard it must be, but imagine being the person who has to look, whose job it is to save someone, and to have to look across someone and say, I can't save you. But what palliative care doctors are really good at doing is saying, I can't save you, but I can help make the time you have left really good. But most doctors aren't trained to have those difficult conversations. So I think that also leads to the inequity. So there's a whole host of things. What have I forgotten, Dr. Banerjee? What are some of the other challenges?
I think you've hit most of them. The one thing I will say is that, palliative care in general is still so inaccessible to most Americans that live in the rural areas, right? Major academic centers have palliative care programs. But if you look at the community hospitals, especially those that are not in major cities, they don't have palliative care access. They don't have hospice care access. They have physicians that really haven't had any training or any basic knowledge of what palliative care can or cannot do. Also, I think one of the issues that comes up is that with a hospice and palliative care team, they almost become the mediaries or the mediators between the primary team of the major illness that that primary team is treating and the patient and their family, right? Because the patients have built this trust with their doctors, and sometimes doctors that are treating them for that long, feel it's a failure for them to say that, your disease has progressed to the point that I can't cure it anymore, right? That's when you really partner with your palliative care physicians and your social workers and your chaplains to bring that multidisciplinary approach to work with both the physicians that were treating that primary disease and the patients and families that are going through this, to really explain to them what the best next steps would be and meet the patients where they are at that point.
So Kim, what are the next steps that Compassion and Choices can do, around this work, really focusing in on fighting the inequities, combating the inequities in end-of-life care?
That's a great question, Cindy. So one of the things that we're really trying to do is partner with organizations that represent historically underserved communities and really lifting up their voices and tapping into their expertise. And we, in October of last year, we pulled together the first ever summit in inequities and end-of-life care that we hosted, along with several partner organizations. So it was Latinos for Healthcare Equity, the National Hispanic Council on Aging, SAGE, who is an advocacy organization for the LGBTQ community, and Noble Women, which is the African American women elected officials, and Vitus Healthcare. And those entities came together with us, and we held a summit around inequities in end-of-life care. The literature review served as the vehicle for us to begin to have those conversations. And we began discussions around what should our federal policy agenda be to address these inequities in end-of-life care. So there is also a report on our website that outlines the findings from that. We're still turning that into fashioning what that policy agenda might look like, but there are some challenges with our payment models around Medicare and Medicaid, as you can imagine, that perpetuate the inequities. Some challenges around how palliative care is paid for that reinforces it ending up in places that have access to more money and more resources to get it started, in wealthier hospitals versus a more community-based model, which is now starting to emerge. And so then we're going to do some advocacy work along with these other organizations to try to get some change to payment structures so that we're able to support improvements into our federal policy around this. At the same time, we have now 4 leadership councils representing different communities. And those leadership councils work with us to do public education, or we work with them would be a more accurate way to say it, to do public education into the communities that are underserved, to raise awareness around the full breadth of end-of-life options and help ensure that those communities have the information they need. And it's everything from creating culturally competent videos, materials, tools, and then supporting research and outreach efforts taking place within those communities. And some really, really tremendous work is taking place by the leadership councils and our community engagement team. And that's work that we as an organization are very committed to and will continue to support.
That is really exciting. I'm going to invite you back right now as you all continue to form your policy agenda on this. We would love to have you all back so that we can kind of dive into this with you again. Kim's going to laugh. We at On Aging this year, we had a dinner. I called it the Women Who Changed the World dinner, because of the way that the women who were there think differently and think about things in a way that will really affect change. And Kim actually sat right next to me during that dinner.
I did.
It was
Dr. Banerjee would fit right in there. She's definitely a woman that's changing the world.
There's a lot of us.
I know, there really are. And I will just say that our leadership councils, at some point, you should have them on to talk about, what are they doing and what are the strategies in their community. These are such incredible people, both men and women, and a lot of transgender too, actually, but just really, really incredible people that are doing this work.
Yeah, this is how we start to move the needle, and the needle needs to get moved a little further every day. Dr. Banerjee, this is obviously something you are so passionate about. Can you talk about how other providers can learn about culturally competent care around end-of-life planning? Are there specific practices that providers can be putting into place? Is there specific areas where they can go to learn? Where should they be looking right now?
I think the first and foremost thing that every provider should do is, look at it from a human aspect. I think they need to take a step back. They need to reflect on themselves and really look at what their own biases are and what their own knowledge gap is in terms of addressing health disparities and inequities. Because until you get a sense and a true understanding of where you stand in this process, you're not going to be able to address it and help those that need that help. I think for physicians, especially with health equity and access and disparities, I think no matter what their specialty is, that they need to look at these issues with every aspect of their care, not just from the curative aspect, but also towards the end of life aspect of it. They need to really engage with their patients in understanding where these patients are coming from, what their challenges are, what the issues are at stake that might prevent them from even getting that access to care or making the right choices for them, regardless of what point in the disease they may be. So I think it also comes down to making sure that physicians start having a more communication-based relationship, and the communication should not just focus on disease management, but should focus on socioeconomic and cultural issues that patients are facing, and then, in all honesty, keep the transparency there. Patients need to know what's happening to them. Patients need to be involved in their decision making, and they need to really be completely present and engaged in their care along with their providers. So I think that would be my advice to physicians. I think for patients, it's really important that patients ask the difficult questions, because if they don't, no one else is going to ask the providers those questions for them. At the end of the day, I think many patients still feel that they can't, or they don't know how to ask physicians these questions. They feel like physicians will get upset, or they may lose their trust in their physicians, or they might, upset their egos, if anything. And I think it's important for patients to understand that it's their body, it's their healthcare, it's their choice at the end of the day. And if they don't advocate for themselves, it's going to be very difficult for others to advocate for them.
Yeah. Thank you so much for talking about this with us today. We are, as I mentioned at the beginning of this, we are getting up and gearing up for our Health Equity Summit Forum will start on Monday. This is such a perfect example of the type of conversations that we should be having when we talk about health equity, and understanding that there is such a broad context to that for every community. We hope everybody will join us at our Health Equity Forum that you can register for on our website, www.asaging.org. And I've gone to Compassion and Choices website numerous times myself at this point for toolkits. I'm assuming that those questions that Dr. Banerjee was just talking about when she says, know the right questions to ask, those are within the tools that you have on your website as well. And that's where, the patients, their families, that's where they should be going to get assistance in this. Is that correct?
Absolutely, Cindy. We have a great tool called the Diagnosis Decoder, which actually gives you a list of questions so that you can become a patient advocate. And I'll just add to what Dr. Banerjee said. There was a study that came out that talked about differences between doctors and patients around the word treatable. And when a patient hears treatable, they believe it means they're going to be cured and return to their old self. But when a doctor says treatable, it just simply means a treatment can be applied to this. It doesn't mean the treatment will work. And so that gap is part of what's causing the challenges. And the study showed that patients asking questions can have a transformative effect on the doctor-patient relationship. So our website has that tool, a host of other things. And if you're interested in the inequities in care, the summit report I mentioned, or the research report, that's also on our website as well, compassionandchoices.org.
Excellent. Thank you all so much. And we will talk to you again soon, I'm sure. Thanks, everybody, and have a great day.
Thanks, Cindy.
Bye-bye.